Hi everybody and welcome to the November 2020 education updates. So just wanted to switch up the format, see what else works. I know I've been sending out the newsletter and I wanted to try out a PowerPoint with narration so that way I'm targeting all the visual and auditory learners. So here's an attempt for this. Here's a nice little quote about education and investment in knowledge, and that pays the best interest, and that's by Benjamin Franklin. Here are our new staff that has joined us recently. For Broomfield, Joseph is a paramedic. Austin Thomas is going to be one of our PRN RNs. And Stephen, Marissa, and Ryan are all cross-trained staff from AMC. Stephen and Marissa are paramedics. Ryan is one of the nurses. For long speak, Megan is joining us. She is a traveler. She's going to be full-time on days. Nick, he's worked for both Broomfield and Long Speak in the past, so you will recognize him. He's going to be joining us full-time on days. And Tyra, I'm not 100% sure if I'm saying her name correctly. I have not met her in person yet, so I apologize. But she's going to be our EMT full-time on mid-shifts from 10 to 10. And then we are also being joined by Rachel, who's going to be full-time night shift. She is one of our fellowship nurses. So you're going to be seeing her around doing orientation for quite a while. I think she's scheduled for a total of 22 shifts. So you'll see her around. Please welcome her. And Matthew Havaniak is a full-time days nurse that's going to be joining us also from AMC, I believe. And he's going to be on day shift as well. We are working on some decon training. Phil and I are partnering up on this. He is going to be providing the training itself, and I'm working with him as a nurse planner for providing some ANCCCs. So more to come on that. This will be offered at definitely a long speak, and I'm hoping we can work on doing this at Broomfield as well. My goal is to try to get as much education for our Broomfield staff at Broomfield as well, so they don't have to travel as much. But stay tuned for more. I'm going to have more information on that as well. There is going to be a new ULearn that's going to be released. I do not have a date on when that's going to be happening yet, but the ULearn is going to be for blood administration. And the big thing about this is the ULearn is actually going to be intended for ED. In the past, if you recall, the blood administration ULearn has been focused on inpatient documentation, which is not really helpful for us when we're trying to learn. We end up having to kind of figure out the documentation and go through it and kind of really practice it in real life, which essentially is what we're going to be doing. But this module at least will be showing us the documentation and what it's supposed to look like for us. So this should have everything that we need, and I believe this will have emergent blood administration for Broomfield as well, and then we maintain the same process for long speed that we have been for emergency blood administration, including MTP. We are going to be switching to TNK. I'm sure you already heard about this. We were going to have a kind of a staggered release, Broomfield releasing in December and LPH releasing in January. The reason for that was because LPH really utilizes the North Neuro Group as Broomfield utilizes the Metro Neuro Group. However, because of some pharmacy delays, we have decided to just launch TNK for both LPH and Broomfield on January 10th. So I'm very excited about this. I think you guys will be too. For those that have administered TPA in the past, you know that it used to be a bolus, then a drip, and then a flush. Well, this is going to be much easier. TNK is just a bolus being pushed over 5 to 10 seconds. So it's super rapid, very quick, no drips, no flushes, and then after you administer, you just do your assessment. The max dose for TNK is 25 milligrams, and that is going to be 0.25 milligrams per kilogram. And it's going to be in a kit in a Pyxis, and it's going to be a sterile water vial, the TNK vial, a 10 ml syringe, and a 5 ml syringe. And the way it works is you use the 10 ml syringe to pull up the sterile water and reconstitute TNK, and then you use the 5 ml syringe to pull up your medication. It's kind of a safety measure because the max dose being 25 milligrams is 5 mLs. So that way you'll never ever administer more than the max dose, and then you can adjust the dose if the person would not qualify for the max dose. Let's see. The TPA is still going to remain. We're going to utilize TPA for our wake-up strokes and pregnancy and pediatrics. And I do realize that pregnancy and pediatrics is kind of a one-off. We hardly ever see these cases. They do occur though, so we have to keep that in mind, be ready for those. And the reason that we do not have TNK ready for pregnancy patients and pregnant patients in pediatrics is because they have not been simply tested. So as we get more research and we find out more about these, then we'll get more data and we'll eventually transition to TNK in these cases. But for wake-up strokes, it's going to be TPA. So we retain the same process for there. TPA still will be there, but specific to dose. Otherwise, any other stroke that is within the time frame for thrombolytics will be TNK. There is a ULearn has been assigned to Broomfield staff with anticipation of the earlier December release, and I am hearing that we are reworking that ULearn to have it more intended for ED. Again, one of the things that I've been pushing for really hard is to have more ULearns that are really ED specific. So that's one thing that should be coming up in the future. So there will be a live journal club on November 28th in the ED break room at Broomfield, and that's going to be from 7 to 8 in the morning. This is hosted by Brenda Nelson, one of our day shift charge nurses at Broomfield. And I'm sure that LPH staff is more than welcome to join as well, so please come and join us. The discussion questions are posted here for you guys, and the article, the picture on the right side, actually, if you click on it, will open up the article. So go ahead and open up the article, review it, read it, and along with that, there is an appraisal form. There is a link on the left side on the bottom there. It should work, and the keyword there is should work. I have tested it in presentation mode. So if you get this PowerPoint and you open it up in the email and it's not working, make sure you open it up in presentation mode, and that link should work for you. So there is going to be a little bit more education coming in the pipeline as well. This is for opiate abuse screening, and I know that we have a ton of screening happening at rapid intakes already, and this will likely be another one that's going to be added on. This is triggered by the SBIRT. So essentially what we're doing here is assessing for ETOH intake, how often, the frequency, all that stuff, and the quantity, and it also assesses opiate use. And if a patient comes back positive for opiate use in an SBIRT, the ask is going to be that you go into the ED narrator and within the assessments find the COWS, which is a clinical opiate withdrawal scale. It is very similar to the MIND scale or the CWA. It assesses all those components but from an opiate perspective. So there's going to be more education coming down the pipeline on this. There is going to be a ULearn attached to this, and I know just another ULearn, so please be patient with me, bear with me. There's a lot of ULearns coming, but fortunately, this will be another ULearn that is going to have ED specific documentation. Another thing that I've been trying to push for, as mentioned earlier, is to have ED specific documentation in these ULearns, so that way you guys are not figuring out how to adapt the inpatient documentation to the ED documentation. As you already know, we are amidst a pandemic, another pandemic which has been going on for a very long time, and that is the opiate pandemic in this country. And this is one of the things that we are doing to target that and aid our patients with opiate issues. So you don't have to do this just yet. It has not gone live. I believe the go live is January. There has not been a concrete date set out for this yet. I will communicate that to you guys as I learn more. But if you'd like to practice, feel free to complete the SBIRT as you are required to do that already, and then look for the COWS assessment and go from there. Once this is launched, it looks like there will be a pathway attached to this that's going to guide you what to do if a patient comes back positive within the COWS assessment. This is just a reminder that at the beginning of the month, I sent out a hypothermia sway. Attached to the hypothermia sway is a quiz. If you complete the quiz with 80% or better, you are going to earn 1 internal CE. This expires on the 30th of this month. Just a reminder, this is an internal CE, so it's good for your annual competency that you are required to have 10 CEs totaled at the end of the year, which will be June 30th. Of next year. This will not work if you're trying to recertify it in CEN or NREMT or anything along those lines. This will only work internally for UC Health. So feel free to complete that. There's a lot of good information in there. The reason we went with hypothermia education for this month is it's a multifaceted reason. We had a recent code that involved a hypothermia component. We worked up this patient for 4.5 hours, and a lot of great education came from that as to why we do that, why we keep going for with resuscitation for so long, and it's addressed in this way as well. There is a component of frostbite in this way that addresses all that. And a reason for that is because we are entering the colder months, and we are going to get a lot more patients that are exposed to the elements that are going to be coming in for hypothermia care or frostbite care. So feel free to do this way. It's open to you till the 30th, and earn one internal CE. Um, I have spoken to the ICU team and the inpatient team in general. They've mentioned that there have been a lot of cases where patients are coming up with indwelling catheters. This is the first time I heard about it, so I don't know much information about that besides what they have told me. So I was hoping to address this within updates for you guys. So whenever you guys utilize indwelling catheters, and obviously we try to push for not using them as much as possible, we have external options, but there are those cases and indications where we have to use an indwelling catheter. And the big ask here is that if you do use one, please document that you have placed one, so that way the inpatient team knows how long the catheter has been in there and if there's been any output from that catheter. And then for our new hires and employees that have recently been hired, um, this is coming down from your leadership team that we need to train you to be cross-trained between the two facilities, BFH and LPH. So if you are done with your orientation, I ask that you get to reach out to me and send me some days that you're available for 4 hours to cross-train to the sister facility. And this is for EMTs, paramedics, and nurses. And that way, you're not expected to pick up shifts at the sister facility, but there might be cases if there's an emergency or an MCI happening, or you're just willing to pick up hours, that you might be sent over to your sister facility. So just reach out to me, send me some dates. I have already reached out to everyone that's on my list. So if you have not heard back from me, or you have not heard from me initially, then you are good to go. If you received an email from me last week about scheduling some cross-training hours, please get back to me with some dates. And then education requests. I am more than happy to help anyone with any education that they need. The only ask is that it's specific. If you're going to ask for a very broad topic, obviously that education might not be realistic or feasible. So if there is enough want for an education, like for example, if we want to do some education on trauma, great, but what do we want to address in trauma? So if you are looking at hemorrhage control, or if you want to want education on controlling gunshot wounds or stabbings or blunt traumas or assessments, stuff like that, ocular injuries, the more specific you are, the more I can kind of narrow in on that and get you the best education possible. If it's going to be broad, then it's going to be kind of a superficial education. It's not going to probably give you anything worthwhile for you other than what you already know and probably your review. But the more specific you guys are, the more I can narrow in on the education you want.